Thank you. Hello, everybody. Thank you for joining us on this webinar. Again, my name is Bernice Vega. I'm the project coordinator for the Area Health Education Center. I'd like to present you all to Dr. Mark Linzer. He's the current director of the General Internal Medicine at Hennepin County Medical Center and the professor of medicine at the University of Minnesota. He has held many academic and professional leaderships, 36 years of practicing medicine. He's been a highly involved, active, and effective clinician, teacher, as well as researcher. He has many scholarly interests in a wide range of areas, including blackout spells and, more recently, physician work life. Currently, Dr. Linzer' area of interest is in relationships between primary care work conditions, stress, burnout, and quality care, which brings us to today's presentation of preventing clinician burnout, personal and professional issues and plans. So without further ado, Dr. Mark Linzer.
Thank you very much, everyone. It is such a privilege to be here today with you. And thank you for taking time out of your busy day to join us. There should be lots of ways to get things to me, raising electronic hands or sending notes or just any questions. I'll be happy to answer. A small group, so if we were sitting in a room, we could talk to each other, and let's try and make it like that. So I think I advanced by clicking here.
One more time. Maybe click there.
Let's try it there. I may need some help from Tricia for advancing the slides. Can you do that for me?
Yeah, I can. Is it not working now?
I think our rights just got taken away.
Yeah.
I did, but I've given them to you, so let me try it one more time. If not, you can just tell me next. Okay.
Yep, when I have them, it doesn't move.
Okay.
Double click it?
Yeah, double click.
Nope. Nope, we'll need to do the next.
Okay.
Thank you.
Okay, and I see Alan Meyer has joined us, so welcome.
Thank you very much.
Yeah. So here we go. Let's see. Next, please. There we go. Okay, next one. With no conflicts of interest to report, research is supported by the federal government, AHRQ. Okay, next one, please. So we'll try to do three things today. Identify features of a healthy work environment, discuss ideas of self-care to protect against burnout, and to process together some collaborative approaches to developing and maintaining a healthy workplace. Next one, please. So burnout's in the news, and physician satisfaction's in the news. I had an interview with the New York Times several years ago, and the quote they chose that I thought was a good one: "It will take real structural change in the work environment for physician satisfaction to improve. Firstly, the data show that we are willing to put up with a lot before we give up." Then I was interviewed by USA Today about 6 months ago for an article that I'll refer to later by Ted Shanafelt from Mayo Clinic, with the prevalence of burnout approaching 50% of U.S. physicians. So that was a big news article that was covered by the New York Times, USA Today, I believe the Atlantic Monthly, quite a few places. Okay, next one, please. Some of the research base for this that we've been working on for the last 15 years. We started with a physician work-life study, 1996 to 98, a national survey of over 5,000 doctors. About 2,500 responded. Some of the findings were that satisfaction is promoted by long-term relationships with our patients, that time pressure, particularly during office visits, decreases satisfaction, that stress is related to a lack of control of the workplace, and that burnout is predicted by several factors, but particularly by work-home interference. Next one, please. This is our burnout model. If you look on the left side, you'll see some of the background variables: gender, age, children, solo practice, academic practice, and work hours. But these do not lead directly to burnout. What you'll see is that there are three mediators, and these are the key mediators: work control, work-home interference, and home support. And those three mediators lead to stress or satisfaction, which then lead to burnout, except for the work-home interference variable that not only affects stress and satisfaction, but goes directly to burnout. So what I often say about this slide is, look back on the left side at work hours. You can have a 70-hour-a-week clinician who's got control of their work environment. They leave work at 6. There's somebody at home making dinner. Somebody's taking care of the kids. So they have no work-home interference. They got plenty of home support. Their burnout is low. You can have a 40-hour-a-week clinician with no control of their workplace. The last patient's 4:40 in the afternoon. Got to pick the kids up at daycare at 5 o'clock. Get home and make dinner, and that person will burn out in no time. So it's not only about the hours. It's really about the mediators. Okay, next one, please. We then did the memo study, minimizing error, maximizing outcome, for AHRQ, looking at the relationship between work conditions, physician reactions, and patient care quality. We did this 119 clinics across the country, 400 doctors, 1,700 patients. Next one, please. So the conceptual model for memo is similar to the burnout model. There are workplace characteristics on the left, the structure and culture of your office or organization. The flow of work, policies and processes and demands or needs from the patients. These lead to satisfaction, stress, burnout, and sometimes an intention to leave the practice. And then those can result in patient satisfaction, trust in the clinician, higher or lower quality of care, and medical errors. But notice the arrow across the bottom that links workplace characteristics to patient outcomes. There's also a direct relationship between the workplace and the patient's experience of care. All right, next one, please. So to measure quality, we looked at 6 patients per primary care clinician with diabetes or hypertension. And then we assessed patient satisfaction and quality of life in the survey. And we did chart reviews to look at how well the chronic diseases, hypertension, diabetes, were managed. Next one. To determine errors, we looked at confidential chart reviews for errors in processes of care, wrong medications, missed prevention activities. Next one. So here are some of our results for the physicians. 50% needed more time for visits. Quarter or more were burning out or burned out. About a third were moderately likely or more to leave their job in 2 years. There were very strong relationships between the work conditions, time pressure, work control, chaotic environments, and organizational culture, and the physician outcomes, satisfaction, stress, burnout, and intent to leave. We also found there were many patient care outcomes that were linked to the work conditions as well. Okay, next one, please. These are some of the relationships between the workplace and the patient outcomes. Where doctors had high work control, their diabetes care quality was better. Where doctors had more time pressure, their overall quality was lower, and they had poorer care for their hypertensives. Next one. When there was more emphasis on information and communication between doctors and nurses, there was higher overall quality and better hypertension care. And one of the most powerful variables, when there was an evident values alignment between clinicians and their leaders, there was significantly better diabetes care and fewer prevention errors. Next one, please. So this is the OWL, the Office and Work Life Feedback Measure that we use to categorize the findings from our survey instruments. And we use the OWL to get a snapshot of an office and give that information to clinicians and their leaders to determine how to move forward, how to assess the environment, and how to make it better. So in this particular OWL, you can see this is a problematic setting. Work control, only 25% had high control. Information communication was high and only 40%. Job satisfaction was high for only a third. Less than half had values alignment. Chaos was high. There was a very frantic pace of work, 65% of people. Time pressure was high. 65% noted they needed more time than allotted for their visits. High stress, high burnout, and 2/3 ready to leave the practice. So if you saw something like this, you'd know that this is a clinic that needed to have things addressed right away. If you want to compare it, you look over to the right-hand column, and you can see the other clinics, work control is high at 68% versus this clinic's 25%, communication information high at 80%, so on. Then below you can see your electronic medical record, your staffing ratios, the number of rooms available, what kind of bottlenecks might be present to care. So the OWL really has 2 pages. The first page is all about the clinician experience and the structure of the workplace. The second page is all about the patient experience and the patient outcomes. So you can look at the patient outcomes. If they're not where you want them, turn the OWL back to page 1 and use page 1 to determine how to improve things for the clinicians and patients. Any questions on the OWL? I don't see a hand up, so I'll go on. Okay, next slide, please. Our current grant from the federal government is called Creating Healthy Workplaces. Sarah Poplow is the project manager for that and put a lot of energy into getting this going today with other people, so we thank her. The Healthy Workplace Project is a randomized trial of quality improvement interventions to improve work conditions and the quality of care. Taking place at 34 clinics in rural Wisconsin, Chicago, and New York. Well, rural Wisconsin, also in the city of Chicago and in New York City. And we're using the OWL to measure the work environment and patient outcomes at baseline and after 6 to 12 months in intervention and control sites. Next slide. First thing that we found is that there's tremendous power in the data. When clinics were shown their OWL data and comparison clinic data, it just stopped people in their tracks. And these data spurred meaningful conversations and movement towards solutions. But once people saw the challenges that they had numerically, it's almost like you could no longer ignore it. Next slide, please. So in terms of job satisfaction, the business case for this, in the Harvard Business School, stocks rose 147% when employee satisfaction rose. In almost 8,000 businesses, productivity and income were tied to employee satisfaction. And at Sears, when employee satisfaction rose 4%, sales increased by $200 million. And customer satisfaction rose. So when people ask why measure the satisfaction of physicians, there might be something in it for everybody. Next one. Please, thanks. When people are dissatisfied, there's more burnout, there's more turnover, which is very expensive for clinicians. There's instability, the patient load, there's reduced patient access to care, patient satisfaction and medication adherence, and patients can disenroll from the practice. So it's a cascade of negative events that can occur. Next slide. Let's talk about burnout a little bit. So burnout is a long condition. It's quite common. When we measured it back in the early 2000s, about 20 to 40% of practicing physicians, more so in medical students, associated with perceived errors by residents. It's 60% higher in women than in men. And as we discussed in an earlier slide, it's mediated by 3 key mediators: home support, work control, work-home balance. And in a particularly highly regarded piece that Tate Chanafel published in 2012, just several months ago, burnout symptoms were present in 46% of U.S. physicians across the board. Next slide, please. So to understand some of the variables that predict burnout, we refer to the demand control model of job stress, published first by Karasek in the American Journal of Public Health 30 years ago. And the basic seesaw there is that demands are balanced by control. We all have a lot of work demands, but if we have control of our workplace, we can apportion them out, we can make it work. But stress increases if demands rise or control diminishes. And then about 7 years later, Johnson and Hall published in the same journal an additional piece in Swedish workers, this is not physicians, showing that support can facilitate the impact of control. The more support, the less stress. So support became another factor that balanced work demands. So the bottom line is support and control prevent stress. If we can't change our demands in the workplace, we need to think about what we can do to improve our control or provide or receive more support. Next slide, please. Now I did my sabbatical in the Netherlands, and we did a comparison there of gender differences in burnout. Remember I mentioned that women physicians burn out 60% more often than men. So in comparing the U.S. and the Netherlands, there was less gender difference in burnout in the Netherlands. In fact, there was no gender difference in burnout in the Netherlands. And then we looked at why and found two things. Women worked fewer hours in the Netherlands. Women physicians, 75% were part-time. Women physicians had better control of the workplace than men in the Netherlands, or at least equal control. While in this country, women reliably have much less work control than men. So what's that about? So one of the things that we've postulated is that more burnout in U.S. women doctors is due to a gendered expectation for listening. There is a much higher expectation that a woman physician is going to listen to a concern than a male physician. So 90% of women patients choose a woman physician. And a majority of female patients will also choose a male physician. But the expectation is that there'll be more interest in listening on the basis of a woman physician. Sound like that? Okay, I could say it again, but most women patients choose both genders. I mean, women will, let me see if I get this right, sorry. So women patients, about 90% of women patients will choose a woman physician. And I'm not sure what it'll be for a male physician. I think it's sort of equal, but I got to go back and check. But there are more female patients than male patients, but they will load preferentially onto as many women doctors as they can find. And the reason is because they're trying to there are counseling issues, and there are gynecological issues, and there are many issues that require time. And the key factor is that there'll be more time pressure on a woman physician than a male physician from the expectation of the patient.
That's great.
And that time pressure is a big predictor of stress and burnout. So in another paper we presented at the Eastern Sociological Meetings, we found that U.S. women doctors described a faster pace, less values alignment with leadership, and in fact on all the organizational culture scales, they scored a lower satisfaction and less alignment than males. So we find that women doctors are facing more challenges in the workplace than men. Next slide, please. Burnout in surgeons is common. Some of the predictors are lack of control, lack of work-family balance, dual-career families, a lot of night call, long work hours, and I mentioned one in particular at the end here, compensation based upon billing. Yeah. So when people are incentivized to see more and more patients, this may result in more patients being seen, but it also may result in more burnout. Okay, next one. I see no hands up, but feel free. So another factor is stress in the electronic medical record. The memo study looked at the relationship between EMR functionality and stress. And we have two findings there. The first is that stress increased from 3 to 3.5 on a 1 to 5 scale as EMR functions increased. And then once people got particularly good at it and it got into the workplace, stress decreased once the EMR was fully functional, to a 3.2, but it never really seemed to go back to the original level. That's the first finding. Stress really rises as you bring the EMR in, and then it falls a bit, but not quite back to the beginning. The second is in fully functional EMRs, shorter visits are associated with more stress, more burnout, and more intention of leaving. So once the EMR is fully functional, if you start shortening the amount of minutes that you have to see a patient, it really ramps up the stress. We see a hand.
Yes, I was just wondering, due to the EMR, is that because there's always problems within a technical system? There's always going to be, needing that IT person for the EMR? Could it also possibly be, transferring records from one doctor to another where one does not have EMR fully functional? Is that like a team? Should that be like a team-building skill?
That's a really good question. We don't know the reason. This is part of sort of what surfaced when looking at the data about functionality of EMRs. These are what we found. Our next grant that we hope to proceed with would ask those very questions of clinicians. What's the extra stress from?
Right. I see.
One of the things that we have postulated is that the EMR makes so many things available in a short time that one of the problems is knowing how many clicks to do with patients in the room and how much should you leave till later in this sort of a stress of information overload.
I see.
But we don't know. Your thought is a very good one. I see some other people joined. We have Kristen Small. Hello, and the other ones we've seen before, said hello to before. Okay, next slide, please. One more burnout predictor is called Career Fit. Tate Shanafelt's group from the Mayo Clinic published this in the Archives of Internal Medicine 3 or 4 years ago. And this is defining the amount of time that you have available to do what you are most passionate about. And what they found is that if the percent of time clinicians are able to do what they are most passionate about falls below 10%, burnout rises dramatically. So I wrote an editorial, was invited to write the editorial for that piece, and what I said was we have to think about trying to be sure that clinicians have time, at least 10%, to do what they care most about. So if they really like teaching, or they really like research, or they really like administration, or they whatever it is, you got to make sure they get at least one session a week to do that. And if not, the odds are that they will be burned out and leaving. And so to prevent them leaving, which costs $250,000 to replace, it's certainly worth investing in time for Career Fit. Okay, next slide, please. So how to prevent burnout? These are some of the factors that we put out there. Flexible and part-time work, leaders modeling work-home balance and valuing well-being, promoting control of the work environment so clinicians have some sense of control of their workplace, limiting the EMR time outside the office and providing sufficient time to use it inside the office, and the bottom line, altering our culture of endurance as clinicians. I didn't know which specialty this would be that would be saying that. It turns out it's from a Canadian ophthalmology journal. So it's Canadian ophthalmologists that said this, and they see 40 patients a day, 5 days a week. And I said, that is a culture of endurance. Next slide, please. So we're coming towards the end here. Now we're going to talk a bit about the healthy environment, what to do to make things better. So I keep referring to the variables. Time pressure, work control, chaotic environments, these are really crucial. Values alignment, keep those big four in mind. Time pressure, work control, chaotic environments, and values alignment with leaders. So let's start with time pressure and control. At some clinics, they've just decided to extend appointment times from 15 to 20 minutes, from 20 to 30 minutes. Or and/or to try and make it more quality time by offloading work that clinicians don't have to do during those visits. Group Health Cooperative in Puget Sound, they put in desktop slots during sessions, so every 4 patients you might have a 5th slot open to catch up on your documentation. And then after a vacation, when you're gone for a week or family leave, you might allow time, 2 hours, 4 hours more of non-booked slots to catch up, because there'll be a lot of patient care work no matter how much coverage you've had. Another one is more order, less chaos. So maximally utilizing your space. When people are all crammed into a small space, it's very stressful. Adding more people in that environment will not help. Get people out over the week, even though at first it's awkward to try and move out of slots that you were sort of used to being in, can be very effective. And, you know, it may take 6 months for folks to change their home schedule to match it, but eventually maximally utilizing space and spreading people out is very helpful. Piloting unique schedules, 7 days on, 7 days off. So you work daytimes in clinics and evening clinics and maybe a weekend on the wards, and then you're off for a week. Somebody covers your in-basket and you're free. And then support for work-home balance. Supporting part-time practice and practice styles, being supportive of parents and young children. Next slide, please. Building forms work at the practice flow. We have a lot of forms here at Hennepin for our city hospital patients. Trying not to wait till the end of the day to have a stack of forms that have to be filled in at 7 o'clock at night, but putting them into the flow so the MAs are sort of getting them ready for you while you're coming out of the room. And Virginia Mason in Seattle does this, and it's very effective. Respect the life cycle. This is one that I brought up in many places. We published this in the American Journal of Medicine 2004. Predictable life events are predictable. They will happen. There will be family illness. There will be personal leave. There will be parental leave. But whenever it happens, everybody starts scrambling to try and provide coverage. You need a small pool of float clinicians to come in and cover. They may not be needed 8 sessions a week, but maybe 4 sessions or 3 sessions. Cover the end basket, cover some of the patients. Building workplace teams. So teams are, of course, a major part of the patient-centered medical home. To address workflow and quality measures, you can't have doctors alone at night looking for the registries and trying to do all this work on their own. Physicians, advanced practice providers, NPs and PAs, MAs, RNs, and PharmDs, whatever iteration of that is appropriate to your setting. And then a supportive culture. So this may take talk time. Bring the leaders, the clinic medical directors, and the staff and the clinicians together. Be sure the values are aligned. Why are we here? What are we doing? Is our workday, does it make us feel like that? Because you have to feel like your values are being lived out every day to work this hard. It's hard work. And then take time to listen. And then sometimes action is not even needed. So I mentioned that last one because everyone says, well, everything costs money. We haven't got the money. And, you know, it's not always about the money. My medical director and I had a faculty member who had a child's birthday that afternoon. We went over to the clinic and said, we're taking over your staffing of the residents today. You can go home and get ready for the party, and go ahead, go. It didn't cost anything. But it will be, I had a picture of that child blowing out the candles, and I'll remember it for a long time, and so will our faculty member. Okay, next one, please. So sort of a wrap-up slide, wellness and work life. You need time to reflect together on challenging cases, exercise, eat, complete work at work. During a visit, see a patient, listen, provide empathy, attend to quality measures, and use the EMR. All that's got to fit in whatever time you allow. If it doesn't, it's not enough time. Huddle with a team can help with all the above. And then leave time for meeting with leaders and discussing values, direction, and purpose. Next one, please. Remember, part-time doctors are key. They're hard workers. The data show they usually work at more than their FTE. They're loyal, connected, they have good morale, patient satisfaction is high, and they may go full-time one day when you want to go part-time, either to raise children or at the end of your career. A lot of faculty in the 60s are going part-time, and then when they finish being part-time and want to retire, they're great float physicians to come back and cover the other people who are going part-time for parental leave. Next one. So one way to get there, create an office within your organization, a professional work life. It's a visible site for clinician wellness. Wellness champions in each setting. Do periodic brief surveys of stress, burnout, and remediable predictors. And then develop focused action plans to promote wellness and see how you're doing. So the next slide has our instrument that was sent out ahead of time. Mini owl is a very, very, very small owl. But it's just 8 questions. But with these 8 questions, you can really get a sense of how your clinic is doing. Are people satisfied? Do they have a great deal of stress? Are they burned out? How much control do they have? Do they have enough time? What's the atmosphere like in the office? Calm, busy, or hectic? Are their values aligned with the leaders of their department? And are their values aligned with their organizational leaders? This is a proposed, very small owl. We really haven't tested this one yet, but it takes the highest profile questions, makes them available to you. And once you've looked at some of these, you say, wow, this is a clinic under stress, or wow, this is a clinic that really figured it out. So the mini owl is a good place to start. Did anybody try filling in their mini owl just to see how it came out? You don't have to tell us what it was, but so we'll be having it. Oh, there's someone. There's a hand up.
Hi, Mark. This is Virginia. This is excellent. I have a question. As you know, our project is engaged with the clinicians in community health centers statewide, and would you comment on, well, many of those people in the safety net, of course, are PAs, NPs, mental health providers, and other health professionals. Would you comment on the generalizability of your findings here to those other health professionals?
Yeah, I would think it's probably going to be good, but we're going to find out more from the Healthy Workplace study that we're completing now. In Memo, it was all physicians, but in Healthy Workplace, we included nurse practitioners and physician assistants. So we'll know more about how that generalizes shortly.
I would think there might be less perceptions of control than with physicians.
I think you may be right. We did a grand rounds here about a month ago, and we did an audience response. We're using the mini owl questions for physicians and then for advanced practice providers, which is NPs and PAs and midwives, and then for residents, fellows, and students. And there was a difference, I believe, in terms of control. So you may be exactly right about that. And again, you know, once people see it, you know, 78% have marginal or poor control, it prompts a discussion. Like, well, okay, what control could we give that would be beneficial? And once people start talking about it, sometimes it's not that hard to give it. It's the absence of data and the absence of a discussion that is problematic. I see a hand. Is that Virginia's hand still or someone else's hand? Virginia. All right.
Well, I'll put my hand up again. I guess I didn't erase it. But anyway, I have another question.
Well, we're almost at the question and answer time, so feel free to go right at it.
Well, I have one more. And with the suggestions that you make here, which I find really interesting and important, about, 10% time to do what you want and what you're really interested in, and some of these things, and of course I'm thinking of community health centers. How could community health centers do those kinds of things? Several of the suggestions you make here, the listening, collaboration, so on, and not have it cost more.
Well, we may have to go back over them one by one, and maybe we'll see what we can come up with. Let's do the last slide, because the last slide, I think, is just thank you. Tricia, you want to just do the last one? Yep, that's it. It's been a privilege to share our research, so we thank you for joining us and listening today, and now it is all going to be question and answer. So, Tricia, if we go back 2 slides or 3 slides. And continue. Going back for a minute. And continue. And one more. All right, so we'll start here. So each one of these becomes sort of a cost benefit. And our contention the whole way with this is that there is a cost to maintaining the status quo. So if the status quo is a burnout rate of between 30 and 50%, and if at least half of those people leave the practice, there will be a substantial recruitment and startup cost based upon that. So I always start by saying there are real costs to doing nothing or leaving it the way it is. So now it's just a question of, well, which one of these things can you afford to put in place to prevent paying what may be 3, 4, or 5 times more in a very short period of time. So extending appointment times, there's been a lot of discussion about that lately. We have a big grant that we wrote about that. If you see fewer patients, what will that do to your productivity? But if you extend your appointment time and you actually are able to manage all the issues that a patient wants in that visit, they don't have to keep coming back and clogging up the schedule with more visits. They're sort of finished. They're satisfied. You do well in your satisfaction measures. You do well in your quality measures, and you have more appointments open downstream for other patients. In terms of offloading non-clinician work, that's a big part of the patient-centered medical home. And so there is some reimbursement for PCMH in terms of care coordination, but that's sort of the genesis of this idea. In terms of desktop slots, the work needs to be done somewhere. If you don't give folks time to do it during the workday, they're taking it home at night. And again, there's a downside to that. There's profound dissatisfaction from working at night when you can't see your family, and there will be a cost to that. Time to catch up, it's the same thing. These are all sort of small fixed costs instead of what we call sort of an enormous non-fixed cost, which results. Maximally utilizing space is a cost saver. It just means people are sitting down and talking about, okay, who's going to give up Thursday afternoon? Who's going to work Friday afternoon? What can we do? And the unique schedule, 7 on, 7 off, involves working evenings and weekends, but then you get off during the week. And so there's all sorts of ways that you can view these as some of these are really revenue neutral. Some of them are going to have to be an upfront cost, but the cost may be relatively modest compared to what it'll be later. Look at the next slide for a moment, if we can, please, Tricia. I'll talk about float clinicians, the second one. That's just a huge one. When you have 3 or 4 people out on leave and your practice size is only 8 or 10 people, everybody's going to feel that. And if you actually get to a point where people get more stressed by the people being out and they start leaving, your practice can completely fall apart, and the quality and errors are going to really plummet. It seems like, again, a cost-effective intervention to have doctors available who will be able to bill for the time they're there, so they're not going to be just, paid and not working. They'll be working, and so they'll be covering many of their costs. So you can see where I'm going with this. None of these are free, or some of them are free. The listening is free, but the rest of them do have some cost. But so what are your thoughts about that, everyone?
Do you think that it would be different now that we're moving more toward medical homes, that perhaps administrators would be more open to making these type of changes so that patient satisfaction can be improved as a result of improving the morale, I guess, of providers?
Yes, I agree completely. I think that, in part, the patient-centered medical home came from wanting to make improvements in these areas.
Got it.
So I really do think that there will be a payoff, and of course there is some finance that comes with a patient-centered medical home. It's not a lot, but it's something.
Right.
Sarah gave me a note that said if you work with a university, they may have funding for the career fit piece. If people get a grant, of course, that covers their time and allows them to do research. So if you invest in research time, but then the first year is the investment, after that you want them to get a grant and pay for it,
Right.
becomes sustainable.
Got it.
So other possibilities, community-based programs, same things, maybe support. There's a pay for performance idea where, a lot of folks are in P4P situations. If you can improve your quality measures by building better teams, the third thing on this slide,
Right.
that may well pay off very quickly.
I have another question. Do you have any research, or do you know anyone who's researching these type of issues, but with psychologists in primary care? Because I'm a psychologist myself, and obviously my training has been very different to what I am doing now. And I was wondering if you knew about anyone who was doing research in this area, particularly for psychologists or mental health in general.
That's really interesting. We have some psychologists working in our medicine clinic, actually.
Right. Mm-hmm.
Thought about adapting this to their environment. I don't know anyone who's doing it. It doesn't mean it's being done.
Okay.
Also, certainly I'm open to, looking at these measures and trying to adapt them for that purpose and trying them out with you.
Okay. That would be, I'm very interested in finding that out. I mean, I know now there are more training programs that are training psychologists for primary care, but I wasn't aware of any research specific to this, so I was curious.
Thinking about the big four: time pressure, work control, chaotic environments, values alignment. I mean, there's a good chance that those are going to be applicable to many groups.
Absolutely. Absolutely. Thank you so much. This has been great, so thank you for sharing.
Thank you very much, Dr. Asenteris.
Yes, thank you.
Other questions, everybody? Alan, Carol, anything? Kristen, Leland? The mini owl look like it may be useful in your setting?
Yeah, as a matter of fact, I think it would be very, very helpful to at least get a good measure of the current state of our clinics and the clinicians working, and maybe start the conversation of what can be improved as a team rather than small little groups talking about it, but nothing actually happening in terms of changes. So it looks great. Thank you.
Yes, we have found in our Healthy Workplace study that was the biggest initial finding, was that by measuring and talking about the measurements, it really got the conversation started.
Got it.
Kristen, it sounds like the microphone is not on, but you are more than welcome. Glad you could be here. Any feedback about the presentation, things that we could include that would be helpful as well, or things that were particularly helpful?
Well, just a comment. There's so much here that could be useful in beginning the discussion with clinic administrators, as we talked about, as well as the clinicians. So I'm glad that Dr. Linzer is planning to do a part 2, we hope, for clinic administrators. And if we can do something in this project to get the dialogue going with both clinicians and administrators in the community health centers, that would be a big thing.
That's a really good point. A lot of times when I do workshops, I really emphasize the importance of having the administrators there as well as the clinicians, because there's only so much you can do yourself. I've got a note from Kristen talking about, how to begin a culture change. How do you put it in practice? And I think that's essential. And to do that, it really requires the people who can make change. So you've got to get the people who practice in the same room as the folks who could change the environment and start to discuss some of the tough logistical questions, cultural change questions, and financial questions. But they're all relevant and they're all hard, but, my real thought is they need to be discussed. And once you start discussing them, all of a sudden you say, oh my goodness, well we could do that. Mm-hmm. Oh, well we could do that. And before you know it, there's real change happening. Sometimes I say, it doesn't take a huge change. If you've got control of 10% of your work and 90% of it you don't, what I say is take that 10% and really control it. I mean, just do something that you really feel is important with what you do control. And at least you'll feel you've got that piece. You may not get the other 80% or 90% too soon. You might get it up to 20 or 30%, but you've got 10%. So do something with that. And then you sort of build on it. Right. And, that makes good how to have control and share it. Yes, Virginia?
Well, that makes good sense to me. Work with what you can work with.
Yeah. Joanna, did you have a comment?
No, that's fine.
Okay.
Thank you.
Alan, I didn't get to hear you sign in. What is your practice? What kind of practice?
I'm actually one of the administrators. I work with the AHEC in San Francisco, so we're involved with the National Health Service Corps and State Loan Repayment Program Retention Evaluation Project. So we are certainly looking to incorporate some of this material into what we're trying to do with the loan repayers as well as their supervisors and practice sites.
Well, that's great. Virginia, it sounds like a great contact for our next call.
Yes, I know Alan very well, and we'll be seeing him tomorrow, and he's part of the Center Director think tank where we're trying to figure out how we might collaborate further on some of the research ideas that have been raised here with you.
Yeah, because, recruitment and retention are a big part of this. And, part of it is the finance. It's very expensive to recruit and lose people. And part of it is just, when you don't have enough people, it's harder work for everybody else. So there's a reason to try and solve that piece. Kristen, I hope you don't mind, once in a while I do quote from the things that you're sending me. But Kristen is saying about how important change is, and that, with so much burnout going on in primary care, it's going to be harder and harder to get people to choose this profession.
Yeah.
And I would agree.
Yeah.
I mean, when I'm sitting there at night at 7 o'clock and my students are leaving, my residents are leaving, and the staff is leaving, everybody sees it, and I'm still there clicking on clicks.
Right.
This is not an advertisement to take over my practice one day.
Right.
I can smile and I can say I like it, and I do smile and I do like it, but it's just a very long work day.
Right.
So I think it is really essential to, take some of these principles. In some ways, this is an introductory talk. It's a glossary of terms. It's the nomenclature of the workplace culture and structure. And it gives us a chance to figure out what would we do if we could change it, what would you change, and how would you go there. So I'm hopeful that this has been helpful to everybody.
Yes, thank you so much
Great.
for sharing. Thank you.
Tricia, do we keep going or should we start?
Very great.
No, we can go ahead and close it. There's no other questions. We can go ahead and just tell everyone thank you for joining us.
Thank you so much.
Thank you so much. Okay.
Thank you.
All right, back.